Okay. Well, welcome everyone to the Halloween edition of High Rounds. I think it's been a little bit since Dr. Mehta has presented, perhaps, but we're always in good hands with him. So, and one of the most modest human beings writes that he's an infectious disease physician at UCSD that primarily works at the VA. Didn't say that he was the chief of infectious diseases at the VA. And one of the very cool things about Sanjay is a variety of interests in ID, from parasites to viruses, but has mostly focused on HIV in his research. And he has officially lived in San Diego more than any other location in his life. So I guess that makes him a San Diego native. And when he has free time, he likes exploring San Diego by bike. So yeah, Sanjay, we'll turn it over to you. I'll keep an eye on the chat and try to only interrupt during for clarifications, and we'll save questions for the end.
Awesome. Thank you, Jill. Appreciate it and good to be back. I will warn everyone, don't look at me on the screen. I lost my bifocals and so I can barely see the screen at the moment. So I'm going to be bouncing back and forth trying to see stuff, but I think I can get through this. So the title of my talk is Allocating PrEP, How Much is Enough? And sort of the genesis of this talk was um, well, here, I'll start and then we can kind of chat a little bit. And please, Jill and Marvin, please monitor the chat. If anyone has a question in the middle of everything, just please shout it out because I think it'll be helpful to talk about things as we go.
You went to mute, Sanjay.
Sorry about that. So yeah, clearly we are prescribing more PrEP in the US. This is just a trend of PrEP prescriptions across the US up through 2024. This is data from AIDSview, and it's closing in on 600K across the US. And this is true. Oops, did I mute again? No, okay. And the same is true in California. We're closing in on 80,000 PrEP prescriptions in California. And the same is true in San Diego. We are continuing to increase at a pretty good clip, which is great. However, the rates of new diagnoses, so granted, this is not necessarily incident infections, but infections that are diagnosed, has sort of plateaued. This is national data, and this is from the CDC, which they haven't published their 2024 data yet. But up to 2023, you can kind of see that at least in the last 3 years, things have sort of flattened and maybe even started trending upward a little bit. We can kind of ignore 2020 as the COVID anomaly, and people are looking into this and trying to figure out, is the increase that we're seeing after 2020 just a function of diagnosing the people that we missed in 2020, or are these new infections? But it's persisting, and here it looks like it's slightly trending up across the U.S. But it's also kind of stably potentially trending up in California. Again, here the data goes up to 2022. There is 2023 data, and it's about the same as 2022. And here in San Diego, we have data all the way through 2024. And again, it's essentially been flat since 2018. So PrEP has been going up like mad, but the number of new diagnoses are not really changing. So that's the sort of the basis of this talk is maybe we can think about why that's happening. What are we doing wrong with PrEP? Because it really seems like it should work. Or are there other things we need to think about? So PrEP clearly works. I love this study. This is the NEJM study for twice yearly lenacapavir that Jill was a part of, where they were able to show that len markedly reduced HIV infections down to 0.1 per 100 person years, where the background rate, which was actually a little bit lower than in other studies, was 2.37 per 100 years. And here they also compared the standard of care, FTDF, which was at 0.93 per person years. And I need to shrink this, sorry. Um, so the incidence rate ratio was 0.04 to background for lenacapavir and 0.39 to background for FTDF, excuse me. So that was about 60% effectiveness for FTDF. So that was a little worrisome. Some of the earlier non-real world studies of FTDF had much higher effectiveness. And when they went back and looked again, I think Jill's presented this already, but all 9 participants in the FTDF group who received the diagnosis of HIV infection had evidence of low or no adherence, right? So clearly that's an issue. And then this was a study in France. This was a real world study of PrEP, oral PrEP effectiveness. And when they looked here, they saw that, again, they had a similar sort of effect. So about a 60% effectiveness of PrEP, which is not what we would expect based on the registrational trials. But it was impacted clearly by adherence. So in those that were taking less than 50% of the PrEP, the effectiveness was only about 18%. It went up to about 70% with intermediate use, and then all the way up to 93% if you were taking greater than 75% of the doses. So oral PrEP works, obviously, but it works well works much better if you take it. So no surprise there. All right. So what's going on? So how do we optimize the prevention benefit of HIV from PrEP? Um, so right, we have PrEP. We're not seeing a decrease in diagnoses anymore. Is it because we're not the PrEP that we're giving out, people aren't taking? So do we need to optimize adherence to PrEP? Are we just not getting it to the highest risk individuals? Do we just not have enough PrEP out in the community, or is it some other reason that we haven't sorted out yet? And so I'm going to try to go through a couple of these and we can think about them a little bit. And again, stop me if anyone has any questions. So optimizing adherence, that's the first topic we'll talk about. So the retail pricing for PrEP, as you guys all know, FTDF, it's roughly around $360 a year, although depending on your insurance and depending on the copays, it can be higher, maybe $750 in some cases. FTAF is still 22 grand a year. Cabotegravir about 24, lenacapavir 28. I looked up the VA pricing because the VA kind of gets like the best pricing of anyone just because of the way they negotiate. And it wasn't, oops, I messed that up. What happened? I didn't fill it in here. This is the wrong slide set. I'm sorry. So VA pricing was actually slightly better. FTDF was around 350 bucks a year. FTAF was around 12,000 a year. Cabotegravir was around 15,000 a year. So a little bit better, but not dramatically better. And then I also looked up the prices from India. In India, the cost of FTDF is around $50 a year, and that's actually probably on the high end. It's probably cheaper than that in most places. FTAF was around 120 bucks a year, and cabotegravir, what I think was around 1,200 a year. And they don't, there wasn't pricing I could find for Len in India as yet. So clearly, there's room for us to come down on these prices. Or come down on prices for PrEP. When we look at the efficacy, the comparative efficacy of FTDF versus long-acting CAB, so this is a little bit of an older study, so they don't include Len in here, but I think we can almost use long-acting CAB as a equivalent for Len. Len is probably a little bit better, but it's okay. So here they're looking at what our willingness to pay in US dollars is on the x-axis. So there are quality adjusted life years. And then on the y-axis is the maximum price in US dollars. And then they separate it out by those with very high risk for acquiring HIV and high risk for acquiring HIV. And very high risk essentially means somebody that had an STI within the last year or reported having unprotected anal sex in the last year. And the high risk essentially is a number. This is from the HPTN 083 trial. Was essentially, I think they estimated 50% of MSM are at high or regular high risk. I shouldn't say regular risk, high risk. And so this is how, if the efficacy of FTDF was around 75%, so it's a little bit higher than we saw in the real world study in France, and probably and even in the Len trial, so maybe even a little bit over, a bit of an overestimate there, and a long-acting CAB efficacy of around 95%. And so essentially the price premium is how much more we would want to pay for CAB than FTDF to reach this quality adjusted life year ratio. And so in the US, I think most of the time we want a quality of under 100,000. So if we look at that, in the highest risk individuals, that would mean if we gave CAB to everyone, we would want CAB to be only about $1,000 more than the price of FTDF, which in this study was, I think, set at $320. If we were only giving it to the very highest risk individuals, then we would set that at 3,500 to meet a DALY of 100,000. If we extrapolate from current pricing of CAB LA, the incremental cost-effective ratio for very high-risk individuals is 1.5 million, and for high-risk individuals, it's 4.5 million. So huge, huge numbers. So not surprising, not anything we don't already know, that we can't give long-acting agents to everyone. We just, the health system can't afford it at current prices. Now, hopefully that will change. But we need to figure out how to select the highest risk non-adherent population to use these. So that's about the only way I can think of to, there are apps, and I didn't look into all this stuff, but reminders and things like that. And those are obviously very, very cheap interventions, and they have some effect. And those are probably some that we can incorporate as well. And I didn't look into those. But in terms of pharmacologic optimization of adherence, at current prices, it's not going to be something that we can do unless we can really unless we really risk stratify people. So what about allocation of PrEP? So we know that PrEP is not equally distributed. PrEP prescriptions or PrEP use is not equally distributed across the US. So this is from AIDSview as well. So here, this is just the rate of PrEP prescriptions per 100,000 of population. And you can see that it varies widely. The darker colors represent areas where there is more PrEP being used per 100,000, and lighter colors where there's less PrEP being used. And this is just of the general population. So another question is, like, how do we allocate PrEP to make it both more equitable, but also more effective in preventing HIV transmissions? So why do we even need to allocate PrEP? So, TDF FTC is cheap, really should cost less than $100 a year in the US. PrEP prevents a lifelong chronic disease. Preventing HIV benefits the individual and society. And in some studies, oral PrEP is not only and this is again an older slide, so it's not only cost effective, but is cost saving in the highest risk populations and very high risk populations. So I don't think we need to. I think we really, really just need to allocate our efforts, because we should, with PrEP being as cheap as it is and as effective as it is if you take it, we just don't have the energy to get it to all the people that we want. And we need to figure out how to allocate our efforts to make sure we get it out to those individuals that are highest risks out in the community. And we should be able to provide oral PrEP for everyone who wants it. All right, so how do we figure out who we need to give PrEP more PrEP to, which populations? Ideally, PrEP provision and uptake. So the giving and the use of the PrEP should be highest in those populations at the highest risk. That obviously makes sense. And how do we decide how to allocate those PrEP efforts? So at the moment, I think there's only one sort of generalized assessment of the equitable provision of PrEP, and that's called the PrEP to need ratio, which many of you have probably already heard of. So the PNR is essentially the number of PrEP prescriptions in a certain population divided by the number of new HIV diagnoses in that population in the past year. So here they are normalizing the PrEP prescriptions to some sort of risk for HIV, and they're using HIV diagnoses as that risk. So geographically, clearly there's an inequity in the provision of PrEP. So here's a map in AIDS view again of the PrEP to need ratio across different counties across the US. And there's a lot of gray counties where there isn't that much data, particularly in the Midwest and the upper West. But if you look, you can see there's a lot of light green really in the Southeast, as we might expect. That's kind of where the lowest PrEP to need ratios are. Higher PrEP to need ratios again are better. And here in the South, we're seeing PrEP to need ratios that are under 10 for sure in many counties. And if you break it down by state, very similar. You see that large swath across the Southeast US where the PrEP to need ratio on average is much lower than it is across much of the rest of the country, and it's mostly less than 11. This is true not just in the US, it's true in other countries too. So this is Canada. So here are the PrEP to need ratios across the different provinces of Canada. Interestingly, Alberta is not included here because their data was so small, it wasn't even, they decided not to present it. But you can see there's really a couple of states that are doing quite well or are doing better than others, where their PrEP to need ratios are, approaching 30, 35, Nova Scotia, British Columbia, Ontario's in the 20s, most recently. This is a little bit older data. This is from 2021. But there's two states in particular here, plus Alberta, that have very, very low PrEP to need ratios. Those are Saskatchewan, Manitoba, and Alberta. And interestingly enough, when you look at a political map of Canada, the dark blue represents the Conservative Party, and those three states are the ones that have the lowest PrEP to need ratio. So this is something politically that seems to match with what's going on in the US. They have a lot more parties, which makes it much more confusing. Yeah. There's also obviously racial inequity. This is the PrEP to need ratio by state, by race, and this is the white race. You can see, except for Mississippi, everyone else has a PrEP to need ratio at least above 11. And then that's definitely not true for Black and for Hispanic. So clearly there's another gap there as well, and true for gender as well, with males on top and females on bottom. So again, here we're looking at how many PrEP prescriptions are given to, so on the bottom map, to women, divided by the number of women that are diagnosed with HIV in the past year. All right, and as you might expect, PNR is associated with social determinants of health. On a county level analysis, counties that had a higher proportion of the population that was African American had a lower PNR. A higher population percentage that was uninsured had a lower PNR, and a higher population that was below the poverty level, interestingly, it was a little bit different. If you were a rural county, then you had a worse PNR, but if you were an urban county, you actually had a better PNR. So some of these programs that we have are doing maybe a little bit better job in the cities than they are across the US. Okay. So moving on to England. So England's an interesting use case scenario as well. So in England, in about sometime in 2020, uh, they essentially started fully reimbursing PrEP through the NHS program. And so the rates of PrEP prescriptions dramatically increased at that point. And you can kind of see that in these numbers. For example, for white men, which is the top line in the table, the PNR pre-commissioning was 7.1, and then for post-commissioning, it went all the way to 96. So this is uh, here they essentially opened up PrEP in 2020, sometime in 2020. However, there's still significant inequity, as you might expect, and really the biggest eye-popping difference was between the PNR, prep to need ratio for white men versus Black African women, where it was dramatically lower. And some variations throughout you can see as well. So, so it's not just the US that there's inequity racially, gender, geographically, in other countries as well. These are Lorenz curves. So in these graphs, essentially on the y-axis is the cumulative proportion of PrEP users in England. And on x-axis is the number of new HIV diagnoses. And it's a they're the for ethnicity and race, which is the left figure, the ethnicities and races are sort of they're ordered from the lowest amount of PrEP use to the highest amount of PrEP use. And similarly, the regions of England, I can't remember exactly how many regions there were, like 6 or so regions of England. They sort of order them. So what if everything was completely equitable based on the number of new diagnoses in the population? Those curves should match that dotted line middle, both for ethnicity and race, and if they're equitably distributed geographically, the dotted line on the right. So the blue curve is the curve for pre-commissioning. So there was already a skew pre-commissioning, and it was, shifted to certain populations and certain geographies in England, and we know from the previous table which populations they were. And what's interesting is then after commissioning, those inequities actually got worse. The curve shifted further right. And it's just another something to think about. Like, the programs that we initiate, I'm sure having more prep out there is great, but we really need to figure out how to catch those populations that are not accessing it for whatever reason. Oops. I will tell you, so here the in this study they did something slightly different. So instead of just using the number of new diagnoses, they also modified that number a little bit by taking out the ones that they felt were late diagnoses. So for example, if there's 100 new diagnoses in a population in a given year, a certain percentage of those will have a CD4 count on diagnosis of less than 200 or present with an AIDS-defining illness. And those are identified if that happens within 90 days of diagnosis, that those are identified as late diagnoses. And so 15 to 20% probably on average, depending on the study, uh, are uh, are late. So the PNR numbers then, so the denominator changes. So the PNR numbers are a little bit higher here because of the way they calculated that. Okay. So essentially, all these studies show that PrEP is not equitably distributed by ethnicity, race, age, and geography. And so one of our questions was, can we address this on a granular level? Can we use these data, which are sort of county level, state level, national level, regional level? Can we start using it on really small populations? It's kind of at a granular level to sort of start to figure out how to better allocate PrEP in a local context. And so this is some work that we've been doing with the Miami-Dade County. This is a project that Susan Little and Natasha Martin are running called the Aspire Project. This is just one of the sub-projects within the study. And so we've been working with the Florida Department of Health and some investigators at the University of Miami and looking at the epidemiology and the molecular epi of HIV in Miami-Dade County. And so the prep to need ratio in Miami-Dade is it's okay, 17. Again, no one knows what an optimal number, optimal prep to need ratio is. We, I think the folks at AIDSview who sort of have coined this term or developed the term, they use a cutoff of 10 for sure. So anything below 10 is definitely bad. But it's probably unclear exactly what a good number is, but it's clear that a higher number is better. So our question was, in Miami-Dade, are there specific demographic groups that are disproportionately receiving less PrEP? And can we predict how much PrEP by gender, age, and year would be expected if it was delivered equitably based on the new diagnoses in those strata? So here, Sanaz Nazari, one of our statisticians, developed a model to estimate the difference between the observed and predicted PrEP by age, gender, I don't know, or gender twice there, but excuse me, and year. And so by when we set our baseline, we set a baseline of male ages 26 to 35 and the year 2021. And this is only looking over data from 2021 to 2023. And so now we're looking relative to that baseline, how much PrEP is being prescribed. And so for females, the relative risk was actually strangely okay. So we were providing more than expected PrEP in Miami-Dade to females. For the younger age group, we were providing a little bit less, although that was not statistically significant. Neither was it for females. And really, the only two that were statistically significantly different were the age group 46 to 45, 55, which was getting a little bit more PrEP than expected. And then, as you might expect, with each passing year that we were seeing more PrEP being used. And so there was approximately 37% more PrEP prescribed in 2023 than in 2021. So not dramatic, nothing really dramatic there that kind of stood out. And then, so next we examined
Sanjay, can I
neighborhoods.
ask a quick question?
Yeah, of course.
Just on that slide, what's
Yeah.
the slide before? What's the purpose of looking at the different years?
Oh,
Since
this one.
you, yeah, since you know that prescriptions are going to go up every year, how
Yeah,
is
I
that
think
valuable
it
data
was
to
sort
have?
of we needed to do that to sort of normalize um, all the other groups, if that made sense. Because we wanted to,
Sure.
we're looking to see if there's changes. The changes in each group was the same each year, and so if there was one year that PrEP prescriptions are going up, it was always going up in females, that would show up in the model as well.
Okay.
Um, so next, we examined neighborhoods to see if the PNR rates were appropriate based on the mix of the population in that particular neighborhood. So Miami-Dade is broken out into 13, they call them neighborhood districts or neighborhoods. And I'll show you a map here in a second. And so what we calculated was the standardized utilization ratio, which is comparing the observed PrEP versus the expected PrEP based on the demographic characteristics of that neighborhood at each neighborhood level. And so, for our standardized utilization ratio was less than one. There was fewer PrEP users than expected in that neighborhood. And if it was greater than one, uh, I guess you could consider that overutilization, but that was not what we cared too much about. So here's a map of Miami-Dade. I don't know how well many of us know Miami-Dade County, but those little colored areas are different neighborhoods. They're not clear neighborhoods. They're just so the way that the county is divided the neighborhoods, so they kind of overlap kind of neighborhoods that we might think of, like Miami Beach and Aventura are lumped together into one neighborhood. And that's number one, which is on the top right. And this is just a heat map of new diagnoses in Miami-Dade. And you can see that there is a small pocket where there's fewer diagnoses, kind of on the coast where you might expect there to be more of a wealthy enclave. And that little upside down L-shaped area in the center, which is the sort of the downtown area. Okay, so now when we map PNR by neighborhood in Miami-Dade, you start to see some differences. So we start to see that there are at least three neighborhoods where there's a lot of PrEP provision, and then a lot of neighborhoods where it's not quite as good. And so this is important, right? So we're seeing some of this may be an artifact of our data, because our data is not at the individual level, but it's actually at the sort of the pharmacy level. And so there may be fewer pharmacies providing PrEP in those neighborhoods, but this is a relatively populated county where there's lots of places where prescriptions are filled. And so there's some signal here for sure. So we got three neighborhoods where we have high PNR ratios, and a couple of neighborhoods where the colors, the heat map shows is very light, where we're seeing definitely a lower PNR ratio. So those might be neighborhoods where we might figure out how to optimize PrEP allocation. And so here are those numbers. And so those lighter neighborhoods in particular are the ones at the top with the lower PNR numbers. So these included neighborhoods of South Dade. The names probably don't mean too much. Opelika, Westchester. And if you start to go down, you see that the higher numbers include North Miami Beach, Doral, Miami Springs, Kendall, some other sort of more coastal neighborhoods. Strangely, Aventura, Miami Beach was still kind of in the middle. Okay, so this is one way to do it. And I'm just here, I just have a map just showing you the comparison here. So we can see that there is some relationship there. So if you look at the neighborhoods where we see fewer new diagnoses compared to neighboring neighborhoods. So I wish I had an arrow that you guys could see, but the triangular one, which is number 5, which is a little bit lighter orange at the top, corresponds to a neighborhood with high PNR. And then in between the darker oranges on the bottom, there's that one neighborhood that's a little bit lighter orange. Again, that also corresponds to one that has a high PNR. The neighborhood on the top that has a high PNR still has a pretty high new diagnosis rate, but there is possibly a relationship there. This is a really busy slide, and I meant to try to figure out how to fix this, but this is looking at those standardized utilization ratios. And really what I want to highlight is what I have in orange. And we looked at this in 3 years. I said 2021, 2022, and 2023. And it's essentially, we found that across those 3 years, there was 4 neighborhoods that really stood out in terms of having a low standardized utilization ratio. And particularly South Dade, which had a ratio of 0.04, so much less than we would expect for that neighborhood. Some of the other ones were in the 0.1, 0.12, 0.13 range. And here I think I just have, yeah, sorry. I think I, again, didn't fix this slide set. I have the wrong slide set here, but I was just pointing out those neighborhoods here. Okay. So that's one way to normalize PrEP to some sort of risk, right? So is to look at the number of,
I'm so sorry. There was a question that, just a clarifying
yeah,
question from Aaron. He said, we're, back before the neighborhood data. Are you including, I don't know if you have to go back, but are you including any data on transgender individuals when you looked at what I would assume was just, sex assigned at birth?
so here, yeah, here the numbers are so small that we kind of just excluded it. Yeah.
Okay, that was my suspicion, and he's just making the point, probably one of the highest risk communities,
Yeah.
but obviously hard to do with small numbers. Okay, sorry.
Yeah, no worries. Good point, Aaron. Um, yeah. So So that's essentially the only way that's really out there to figure out how to better allocate prep is that P&R ratio. So we were sort of thinking about this, right? So the English did that little tweak to that where they removed the new late diagnoses. So kind of really focusing on the ones that they thought were at least not late. Um, we suggested this other possibility where because we do have access to the molecular data of what about if we look at the prep to clustering ratio. So here we are, instead of using the denominator being the number of new infections, we are actually looking at those infections that cluster because they are linked with a genetic distance of 0.5% or less to another sequence in Miami-Dade. And so what we think that means is a genetic distance of 0.5% means that the evolution of the virus, well, the time from the most recent common ancestor is presumably less than 3 years. It could be a lot less, it could be a little less. That part we're not clear about. So we're looking at more recent infections. And we thought that maybe this, and it's not a perfect measure as well. And we are missing not a small amount of the sequence data. We only have about half of it. But we thought it may be a better way to normalize PrEP prescriptions to better understand or better allocate it to where transmissions are actually occurring more recently. So here our PCR, our PrEP to clustering ratio, again, our calculation is essentially PrEP prescriptions in a population divided by the number of new diagnoses clustering at less than 0.5% in that population in the past year. And as I mentioned, it's a proxy for recent transmissions suggesting less than 3 years of diversions. So when we looked at PCR in comparison to PNR, the maps don't look dramatically different. Those three neighborhoods still kind of had the highest both PCR and PNR. However, there was one kind of shift, and this was in this neighborhood, Kendall, where it was slightly darker at a more normal PNR ratio above 10. But when we started using the PCR calculation, its count or measurement dropped. And again, we see that in terms of those that here we have listed as PNR clustered, but you can see that the South Dade, Opelika, and Westchester remained some of the lowest neighborhoods with PNR clustered. But if you go down to Coral Gables, we see that this one is actually has a lower PNR clustered than we would expect for its relative to where it sat with the PNR. So there's a few more transmissions going on, or a few more clustering infections per the number of PrEP prescriptions provided in that neighborhood. All right, so just a thought, just another way we can think about allocating PrEP to get it to the populations with the most active transmission. Again, when we talk about allocating PrEP, I'm really talking about allocating our efforts to get the PrEP out. So the last sort of way that I think we can sort of optimize PrEP for prevention is making sure we have enough of it out there. Um, and this has turned out to be a tougher question to answer. And clearly not still were answered, but how much PrEP is enough for it to be effective on a population level? So this study came out last year, I think. It's a study done by Patrick Sullivan and his team, and they essentially looked at state level PrEP rates, and they looked at new diagnoses from 2012 to 2022. And they adjusted, they kind of, they estimated the number of individuals at risk by calculating the number of individuals that, number of at-risk MSM, at-risk heterosexuals, and at-risk persons who use injection drugs. All those were calculated using data from NHANES and sort of extrapolated. So there's a lot of extrapolation that occurred here. NHANES and other the American Census Survey. And then they separated the states out into 5 quintiles of PrEP coverage. And then they looked at trends in new HIV diagnoses. And what they showed was a dose response between the provision of PrEP, so the amount of PrEP being provided, and the estimated annual percentage change in the uh, number of new diagnoses. And you can see that the fifth quintile with the highest PrEP provision had the greatest estimated annual percentage change. And then the District of Columbia was just a massive outlier, so they took it aside. Okay, so this kind of shows or suggests that PrEP is working. Um, and we just, the places that have more of it, we're seeing more of an effect. And this is just breaking it down by race, and you can kind of see, although the trends vary a little bit, the top is black, middle is Hispanic, and the bottom is white. There's at least a general trend to the highest quintile having the most the greatest decrease in annual change in prescriptions. So we tried to look at it in Miami-Dade. So here in Miami-Dade, we look at, here's the number of PrEP prescriptions, and it's gone way up. It went from 2018 to 2023. So over the course of 5 or 6 years, we went from around 2,000 to almost 16,000. And I know this, it's a little hard to read because the numbers are a little different, but there wasn't much of a change in the number of new diagnoses. So the number of new diagnoses is in orange. The red is a estimate of the number of recent diagnoses. It's not a great estimate. But you can kind of see that again, after that dip in 2020, things are actually trending upward. So Michelle in our group, Michelle Trong, kind of did a few analyses here, and she plotted each neighborhood with the number of recent diagnoses that were in that neighborhood. And she took each year as well and tried to see if there was a correlation between the number of PrEP prescriptions and the number of recent diagnoses. And you can see here there was essentially no relationship whatsoever. Then she looked at the change in PrEP. So if a neighborhood had went from like 5,000 prescriptions to 6,000 prescriptions the next year, did that have an impact on the new diagnoses in the next year? So did it go from like 10 to 4? And here again, here we actually saw, I mean, not really any much of a relationship as well. If anything, it looked a little negative. We looked at it by gender. And so here we have the y-axis is a little bit easier to read. So the case counts are on the left and the PrEP prescriptions are on the right. But as you can see, as the PrEP prescriptions kind of were increasing, the actual number of new diagnoses, except for 2020, remains pretty flat. And then we did this by neighborhood as well. And for 12 of the 13 neighborhoods, there was no relationship whatsoever. In Aventura, Miami Beach, there may have been a slight relationship here with a slight decrease in new diagnoses in relation to an increase in PrEP. So what's going on? So when we calculated our estimated annual percentage change in new diagnoses, it was much smaller, 0.5%, and that wasn't even statistically significant. And when we looked at the actual effective PrEP on new diagnoses, we essentially saw no effect to potentially, essentially no effect whatsoever. So what's going on? So we took a step back, and so now I'm going to present a few models of PrEP, and these are models. Many of them are published in the like 2018, 2020 era. And all of them show, well, I'll go through them one by one. So here's a model of the UK. So in the UK in 2016, there was roughly 585,000 individuals that were MSM, of which 55,000 were living with HIV. And in 2018, there was about 10,000 people on PrEP. 10,000 of those MSM were on PrEP. So they estimated that if they were giving about 4,000 new prescriptions a year, that by 2030 they would have 40K individuals on PrEP. And so they expected, if that was the case, this is going to be our graph here. And so there's huge confidence intervals, which makes it a little hard to read. But the top line is no PrEP introduction, and the bottom purple or the lighter purple line is if there was PrEP introduction at that level. And so their expectation was, we're 2025, 2026, that we'd see at least a little bit of a drop, 400 or 500 cases per year that would decreased. And this would continue over time and then sort of plateau. So what actually happened is that by 2024, they had way more than 40,000 PrEP users already. So not, they were expecting that by 2030. They're already at, and these are just numbers per year. So the PrEP need is not exactly how many people are on PrEP, because those are the ones that need it, and there's a small percentage that aren't getting it. But if you sort of add up those 2024 numbers, you'll get close to the number of people that are on PrEP. And so it's over, it looks like it's over 100,000 or close to 100,000. So more than double. But what happened in the UK is that the rates of infection actually went up. Similarly, there's a model that was published in the Netherlands. And here they essentially expected a similar thing when each of those colors represents the brownish purple line on top is the base case, and each of those colors represents increasing amounts of PrEP provided, ranging from 3,000 to 15,000 individuals on the waiting list. So there's a waiting list in the Netherlands. And then on the bottom is a bar graph with the expected number of cumulative new infections averted. And so again, seeing that if there was a large increase in PrEP, that they would expect to see a noticeable difference in the number of new diagnoses. And again, what they're seeing is this data includes much older data. These graphs include much older data, but you can kind of see that tail end from 2020 to 2024, that everything is sort of just leveled out. And maybe some of this is projected and maybe even going up a little bit. And an interesting thing that they noted is that an increasing proportion of the persons with new diagnoses, so all the way above 10% now in 2023, had access to prior PrEP. It wasn't clear if they were still taking it or they had sort of come off of it, but at some point they had been on PrEP. All right, so then here's San Francisco data, kind of the same thing. So on the left are prescriptions of PrEP. Um, excuse me, the proportion of MSM in San Francisco that are currently on PrEP. And by 2024, you can see that they haven't broken down by race, ethnicity, but again, not fully equitable, but for the white, Latino, and Asian Pacific Islander, the rates of the proportion of MSM on PrEP was over 60%, while for African Americans it was closer to 50%. And on the right is a network model of San Francisco, the San Francisco HIV epidemic, and they looked at three sort of scenarios of coverage. So they looked at modeling it with low ART coverage, regular ART coverage, and high ART coverage. And I think San Francisco probably fits best in this high ART coverage. And then they added in PrEP coverage. So ART coverage is essentially the proportion of individuals that are living with HIV that are on treatment and are undetectable. And I have those definitions. I forgot to put them on this slide, but how they define low, empirical, and high. But on the bottom, on the x-axis, is the proportion of individuals on PrEP. So this was published in 2021. So again, a couple years before the PrEP data there. And so if you kind of scan down, you can see kind of that 62% line, which is almost all the way to the right. And we talking about a high ART scenario, that is a pretty low level of incidence per 100 patient years. And somewhere on the order of 0.1 or 0.2. And so here's the actual data. So here again is the case count. And the case count is the one in red. You can kind of see that from 2020 to 2024, again, it's sort of just flattened out. It hasn't really decreased. And so this is my sort of back of the envelope calculation. So there's about 65,000 MSM living in San Francisco, about 10,000 are already living with HIV, and about 60% of those that are not living with HIV are on PrEP. So that model suggested about a 0.26% incidence. And the actual number of incident cases was actually only about 90 among MSM. And that actually translates to about 0.16% incidence. So it actually, this plateau, at least in San Francisco, is kind of what's predicted. It seems like it should be lower than it is. So essentially, kind of putting those models together, models suggest that at least 30 to 50% of the high-risk population should be on PrEP to see a 50% drop in incidence. Decreases in transmission are being seen, but seem to stop at an elevated baseline. And there's some baseline that last mile is going to be very difficult to get to. And we might be seeing an increase in new diagnoses. That part, I think, is still to be determined. So why are we
Hey,
not?
just
Yeah,
letting you know there's 5 minutes left, and I'm sure
yeah,
people are gonna have questions. So just yeah.
yeah. I think I got one more slide left. That's it. So why do we not see a dose response? So possibly the impact of PrEP was falsely increased by decreases in new diagnoses in 2020 to 2022. I'll point out in that Patrick Sullivan study, the last year in that study was 2021 or 2020. So if you, that's where I think the decline was seen. And so I think if you remove that year there in their data, it may not look as good as it did. I don't think it would. PrEP might not be reaching the highest risk individuals. If we talked about the right networks, it's inequitably distributed. There may be adherence issues, behaviors evolving potentially in response to PrEP. And then I think the one thing we sort of haven't really sorted out is there's people moving between low PNR and high PNR regions, and maybe that's sort of maintaining that baseline. So Dr. Wertheim, our own Dr. Wertheim, is working on the impact of why we see these sort of this dip in diagnoses in 2020 during COVID and why it's bumping back up. I think the others are probably true and probably all sort of contributing. Um, and I think migration between kind of areas with high PNR and low PNR is probably an issue, a real issue. And that we're not going to see sort of localized numbers change until we do a better job across the country. And with that, I'll just want to thank all the people that helped me with this: Michelle, Sanaz, Dr. Little, Dr. Goyle, Natasha, Dr. Martin, Dr. Shackman and Dr. Wertheim, and then the team at the Florida Department of County Health, Colby Cohen in particular. So thank you. Cool.
Thanks. Thanks so
Question.
much, Sanjay. This is great. Of course, I don't know, for people who aren't Florida natives, maybe a little hard to understand some of the nuance in the different places, although maybe people know better than I do. I hope you will consider doing something similar in San Diego, but maybe that's limited by funding and all the other things. But something would be very cool here. Um, Comment from Fernando that I will just read it. You know,
Yeah.
not a new impression, but at the patients that he sees, newly diagnosed with HIV, that the PrEP message still isn't getting to the people that, there's still groups of people that are not getting the PrEP message, and those would be, people who are crossing the border, engaging in commercial sex work, injecting drugs, and heterosexuals. And I agree wholeheartedly. I mean, we could talk about this for a very long time. I'd love to chat with you more, but I mean, to me, not reaching the right people is still one of the biggest issues. So I don't know if you have thoughts about
You
that.
know, I think for sure that's definitely a huge issue. How do we do that? That's really trying to, and that's the point of sort of the granular PNR, to kind of drill down a little bit if we can. I don't know if it's that helpful yet. I mean, Fernando probably knows more than anything, like who we need to target, and we just need to figure out how to get them access. Yeah.
Yeah, and I think Susan answered the question about access to PrEP prescription
Yeah.
records, probably in different places, and why that's hard. But I'll be quiet. Anik, go ahead.
Thank you, Sanjay. That was great. I hope we can answer this in 1 minute. But I was curious about the Washington, D.C. outlier and wondering if you think that it's being much more effective there because of better PrEP to need, higher PrEP to need ratio, or even the clustering one that you developed. I mean, I know that you haven't tested it, but could it be the reason why we see such a strong effect there?
I do. They have a very high prep to need ratio, and they've done a fantastic job of getting it out. I think it helps also that Maryland and Virginia are not bad either. So I think that region is I think they've done a great job of getting prep out. I also think that there was a well, there's sort of a bimodal transmission population in the DC area, and again, it's still, I have to go back and look at the data, but it wasn't a there's still a lot of equity issues in DC, and so the prevention benefit's been seen higher in the affluent area for sure than the other southeast part of DC.
Yeah.
Susan.
Thanks. Great talk, Sanjay. I think we've discussed this, but I don't remember. We know that the highest rates of new infection are among younger individuals, 25, 35, and the rates of PrEP are often highest in older populations. And I was just curious if you'd looked at age as a specific, yes, age as a particular stratification in addition to race, ethnicity, transmission risk, et cetera.
Yeah, we did that in Miami-Dade, and unfortunately, that group, that 13 to 25 group, which I think is the hardest to reach and where stuff happens was lower than expected. So they were, I think, 13 to 15% lower than expected there. So it's a hard population to get PrEP to,
Yep.
though.
Yeah, there's so much we could talk about here. I certainly will try to one-on-one dialogue. I know this goes on in other groups, but it is after the hour, unfortunately. I have so many things I could ask you, Sanjay. Um, so
Sure.
well presented, though, very interesting. I do like this, the prep to need ratio of thinking about 10, less than 10. I wasn't aware of that, so it's an interesting number to sort of use. I know maybe not, I shouldn't say that officially, but it was nice to see all this data together, sort of, bigger data. Really appreciate it, of course.
Awesome. Well, thank
Thank
you.
you.
Yes, thank you, Sanjay. It was awesome. I'm glad it's recorded.
Yeah, and just yeah, and just so everyone knows, if you're still listening, rounds are in person next week, and we're having a visitor from the California Department of Public Health, the chief. We didn't know that she was coming in person. It was a surprise to us, Kathy Jacobson. So we're gonna see if she's gonna be here for a while, because there may be people who want to meet with her to discuss, projects and things that can be done. So stay tuned. I will send out emails to people that I know that are involved, but if it's something that you are specifically interested in, you're hearing this, let me know. But we hope she'll be here for at least the morning to try to meet with some folks. Anyway, Sanjay, thanks so much. And we'll see everyone next week, hopefully in person.
Great.
Bye.
Thanks, everyone. Cheers.